Hello, everyone. My name is Renee Garcia. Thank you for joining me today. I will be going over my final project for the master's program, and I'll be discussing vitamin D supplementation for inflammatory bowel disease. First, we'll go over an introduction to inflammatory bowel disease, go over the background and significance of research, the purpose of research, the research question and PICO format. I'll cover the definition of terms. I will be discussing 7 different research articles and the key findings involved in those. I will be providing some summaries and key takeaways from the research, and finally, my references. First, an introduction to inflammatory bowel disease. Inflammatory bowel disease, or IBD, constitutes 2 autoimmune diseases that affect the GI tract. This includes Crohn's disease and ulcerative colitis. Like other autoimmune diseases, the body mistakenly attacks healthy cells in the intestines, recognizing them as foreign bodies. Long-term activation of the immune system leads to chronic inflammation. The etiologies or causes of IBD are unknown at this time, though some researchers believe there is a link between vitamin D deficiency and development of autoimmune diseases. There are numerous treatments, but no cure at this time. Some of the treatments include medications like biologics that are local and or systemic immunosuppressors. These medications can help lead to remission where flare-ups cease and clinical symptoms resolve. These 2 conditions are diagnosed with an EGD or esophagogastroduodenoscopy, as well as colonoscopy. In these tests, biopsies are taken to check for distortions in intestinal structures and increased presence of immune cells. Doctors also perform visual inspections, checking for inflammation severity as well as the presence of ulcers. Here we just have a comparison of the two IBDs. We have Crohn's. Crohn's can affect any part of the small intestine or colon, generally affecting just segments. In rare cases, it can be seen in the esophagus and stomach as well. When this disease is unmanaged, it can lead to chronic inflammation and development of non-bleeding or bleeding ulcers, which leads to bloody stool. This can also cause damage to the villi of the intestine and lead to nutrient malabsorption. If the inflammation continues for long periods of time, this can cause further complications, requiring bowel resection to remove damaged or infected tissues. Ulcerative colitis involves the colon, not the small intestines. It does involve the colon, rectum, or anus. It also causes chronic inflammation, as well as bleeding ulcers. Therefore, bloody stools are common. We also have nutrient malabsorption here due to the inflammation and damage of the intestines. Damaged or infected tissues may require bowel resection or colostomy. In some cases, colon cancer may result. Some common symptoms that IBD patients experience are abdominal pain and cramping, chronic and frequent diarrhea, as well as bloody stool. Common complications include unintentional weight loss, which can be the result of restricting specific foods from the diet that are thought to aggravate symptoms, decreased appetite, and that chronic and frequent diarrhea. Macronutrient malnutrition is also common and can result in muscle and fat loss. Micronutrient malnutrition is often related to malabsorption and the frequent diarrhea. If the inflammation is continued for long periods of time, we can also see infections and the possible bowel obstruction, which then may require some surgical interventions. Moving on to background and significance of research. In 2023, Crohn's and UC ulcerative colitis were estimated to affect between 2.4 and 3.1 million adults in the U.S. IBD has shown to negatively impact quality of life, QOL, most likely due to symptoms including frequent diarrhea and abdominal pain. IBD patients are at increased risk of various micronutrient deficiencies, with the most common being B12, folate, vitamin D, and iron. It is estimated that almost 60% of IBD patients have vitamin D deficiency, which is considered less than 50 nanomoles per liter, and that over 30% of IBD patients have serum vitamin D levels that indicate vitamin D insufficiency, and that is 50 to 75 nanomoles per liter. Researchers have found that vitamin D deficiency can lead to worsening symptoms such as increased inflammation and increased disease severity. Here we have a diagram showing the different layers of the intestinal walls. I'll be highlighting just the epithelium and lamina propria, as these two layers are affected significantly by vitamin D status. In the epithelium, vitamin D works indirectly by promoting calcium absorption, which is required for adequate mucus production. Mucus makes up the innermost layer of the intestines and creates a protective barrier. Vitamin D is crucial in the formation and strengthening of tight junctions within the epithelium, which create an additional barrier, preventing matter from leaking from the intestines and into the bloodstream, which is referred to as leaky gut. Additionally, vitamin D also slows the cascade involved in apoptosis of intestinal epithelial cells. The lamina propria is the layer directly under the epithelium and which secures the epithelium in place. Here, vitamin D promotes synthesis of small peptides, referred to as antimicrobial peptides, or AMPs, which are important for protection from harmful pathogens. Vitamin D also suppresses inflammatory pathways that involve the group of proteins called nuclear factor kappa B, which we can see there as NFKB. Additionally, vitamin D also leads to decreased production of fecal calprotectin, which is a substance produced by immune cells within the intestines when inflammation is present. Next, we'll go over the importance of vitamin D for IBD. Researchers have noted once again that vitamin D status is associated with disease severity and that lower levels result in increased inflammation and clinical symptoms. Improved vitamin D status has been shown to decrease the following inflammatory biomarkers: C-reactive protein, or CRP, fecal calprotectin, interleukin 6, or IL-6, nuclear factor kappa B, or NFKB, and tumor necrosis factor alpha, or TNF-alpha. Reductions in these biomarkers are associated with improvements in clinical symptoms. Now we'll go over the purpose of this research. We'll highlight the effectiveness of varying vitamin D dosages across different lengths of study. We'll be comparing changes in key inflammatory biomarkers related to vitamin D supplementation. I'll also discuss the effects of vitamin D supplementation on perceived quality of life, and we'll emphasize the importance of vitamin D supplementation to improve serum vitamin D status. Next, we have the research question, which will be in PICO format. In adults with inflammatory bowel disease, does supplementation of vitamin D compared to placebo or no supplementation reduce inflammatory biomarkers and improve clinical symptoms? And here we have a pretty lengthy list of definition of terms. Inflammatory bowel disease is a group of autoimmune diseases, including Crohn's disease and ulcerative colitis, which cause chronic inflammation in the GI tract. Crohn's disease is an autoimmune disease that causes inflammation anywhere in the GI tract from esophagus to anus, often resulting in ulcers, GI symptoms, complications, and nutrient malabsorption. Ulcerative colitis is an autoimmune disease causing chronic inflammation in all or part of the colon, often resulting in formation of ulcers, GI symptoms, complications, and nutrient malabsorption. C-reactive protein, or CRP, is a positive acute phase protein that increases in the body as inflammation increases or worsens, or if severe infection is present. CRP is synthesized in the liver and activates the immune system, resulting in systemic inflammatory response or reaction. HS-CRP, or high-sensitivity CRP, measures lower levels of inflammation that are associated with chronic disease. Fecal calprotectin is a positive acute phase protein released from white blood cells within the intestines. Neutrophils are sent to the intestines to cause inflammation and release the protein calprotectin. More calprotectin means more inflammation. Cytokines are proteins acting as messengers within the immune system that help regulate inflammation. Interleukin 6, or IL-6, is an inflammatory cytokine that promotes synthesis of acute phase proteins like CRP within the liver. It activates both innate and adaptive immune responses that lead to production of antibodies. Tumor necrosis factor alpha, or TNF alpha, is a pro-inflammatory cytokine associated with chronic inflammation and autoimmune disease. Nuclear factor kappa B is a protein involved in regulation of gene transcription related to inflammatory response. Antimicrobial peptides, or AMPs, are short-chain amino acids, called peptides, produced by epithelial cells within the gut, playing key roles in protecting against infection and maintaining intestinal homeostasis. Vitamin D, I'm sure as we all know, is a fat-soluble vitamin playing key roles in immune function, calcium absorption, bone growth and maintenance, muscle contractions, and neurotransmissions. Apoptosis is often referred to as programmed cell death. It regulates cell production and populations and is crucial for proper tissue homeostasis. And our last two definitions, the intestinal epithelium is the surface layer or innermost layer of the intestinal lining where mucus is produced and secreted to form a protective barrier, preventing harmful substances from leaving intestines and entering the bloodstream. Lamina propria is the connective tissue lying just below the epithelium, which holds the epithelium in place. It is also host to numerous types of immune cells involved in immune function and immune response. Next, we'll move on to our 7 research articles. Beginning first with a study from the Saudi Journal of Gastroenterology. It was published in 2016 and took place in Tehran, Iran. The study duration was 90 days and included males and females between the ages of 18 to 50 with ulcerative colitis. A total of 86 subjects were analyzed at the completion of the study. Subjects in the intervention or vitamin D group received a single 300,000 IU injection of vitamin D3. This resulted in a 33% decrease in high sensitivity CRP, while the control group experienced a 1% increase in this inflammatory biomarker. The p-value of 0.036 meets the requirement of less than 0.05 to show that the results are most likely not related to chance. Next, this study was published in 2022 in the Journal of Gynecological Endocrinology, where researchers were testing the effectiveness of 20,000 IUs of vitamin D2 given 2 times per week for 12 weeks. They were testing how this affects the high sensitivity CRP levels. The subjects were Thai menopausal women between the ages of 40 to 60, with a total of 76 subjects analyzed at the completion of the study. Here, we can see that the vitamin D group showed an average of 19% decrease in high sensitivity CRP, while the control group had an average of 7% decrease. The p-value here is 0.024, which once again shows that the results are most likely not related to chance. This next study is unique in that the participants were children between the ages of 5 and 18, all previously diagnosed with either Crohn's or ulcerative colitis. The vitamin D group received 2,000 IUs daily for 6 months, while the control group received a placebo. The study was published in 2021 in the Journal of Clinical Gastroenterology and took place in Tanta, Egypt. Researchers tested the effects of vitamin D supplementation on 3 unique biochemical markers, as well as disease and symptom severity, using the IBD QOL, or Quality of Life Survey. The results were actually pretty surprising for the vitamin D group. We can see that the CRP decreased by an average of 76%, while the control group only saw a 7% decrease. The p-value for this was 0.0001. This is statistically significant, and it validating that the result is most likely due to the intervention itself rather than chance. For the fecal calprotectin, there was a 46% decrease in the vitamin D group and a 3% decrease in the control group. For the tumor necrosis factor alpha, the D group had a 60% decrease, while the control group actually had an increase of 6%. And concerning the perceived quality of life using the IBD QOL survey, the vitamin D group showed a 45% improvement in their scores compared to 3% improvement in the control group. In surveys like the IBD QOL, higher scores indicate higher quality of life. So these are pretty significant findings for this study to see such a big jump in improvement. Next, we'll go over a study that took place in Lebanon and was published in 2020 in the Journal of Nutrients. The 88 participants analyzed at the end of the 6-month study duration included adult men and women previously diagnosed with diabetes, all with non-obese BMI statuses. The 2 inflammatory biomarkers studied were HS, or high-sensitivity CRP, and the tumor necrosis factor alpha. Participants in the intervention group received 10,000 IUs of vitamin D3 3 times per week versus the control group receiving a placebo 3 times a week. Concerning CRP, we can see that the vitamin D group experienced an average decrease of 46% compared to a 2% decrease in the control group. For the tumor necrosis factor alpha, the vitamin D group and control groups showed 15% and 1% decreases respectively. Both biomarkers had a p-value of less than 0.0001, indicating that the results are most likely to have occurred due to the intervention. Here we have another study implementing a higher dosage of vitamin D. This study was published in the Journal of Clinical Nutrition in 2016 and was conducted in Sao Paulo, Brazil. A total of 38 participants completed the study, which was composed of adult men and women aged 18 to 80, previously diagnosed with chronic kidney disease, or CKD, and receiving hemodialysis. Researchers were testing the effectiveness of 50,000 IUs of vitamin D3 given twice per week for a total of 12 weeks, as compared to a placebo. The 3 biomarkers being analyzed were CRP, TNF-alpha, and serum vitamin D status, or 25-hydroxyvitamin D. Starting with CRP, the results showed average decreases of 44% for the D group, compared to 16% decrease in the control group. The TNF-alpha data shows for both vitamin D and control groups that there was a 15% decrease. And lastly, the vitamin D status of the vitamin D group increased by 201%, while the control group actually experienced an average 3% decrease. As mentioned previously, we know that a higher vitamin D status is linked to decreased disease severity, which makes these results very important concerning disease management. For the CRP and 25-hydroxyvitamin D results, the p-values were both less than 0.05 and therefore demonstrate the results are most likely not related to chance. Moving on, we have a study published in 2020 in the Journal of Dietary Supplements. This study was conducted also in Tehran, Iran, with the participant population including adult women and men aged 26 to 73, either with stage 2 or stage 3 colorectal cancer, and receiving chemotherapy 2 times per week. The researchers analyzed CRP, interleukin-6, and TNF-alpha, as well as measuring serum vitamin D levels. The vitamin D group received 50,000 IU vitamin D3 dose per week, while the control group received a placebo, all for a total of 8 weeks. Beginning with CRP, we can see that the vitamin D group saw a 23% decrease compared to a 6% increase in the control group, with a p-value of 0.001. For TNF-alpha, the results were 17% decrease and 1% decrease for the vitamin D and control groups respectively, also with a p-value of less than 0.001. Interleukin-6 decreased by 14% in the D group and less than 1% in the control group, with a p-value also of less than 0.001. And concerning serum vitamin D, the D group had an average increase of 224% versus a 45% decrease in the control group, with a p-value of less than 0.001. All results are statistically significant, showing that even short-term vitamin D supplementation can positively impact inflammation. And finally, coming to the last study, published in 2020 in the ESPEN Clinical Nutrition Journal. The study took place in Tehran, Iran. Participants were adult men and women aged 18 and older with mild to moderate ulcerative colitis, with 46 participants completing the study. Researchers tested the effectiveness of 2,000 IUs versus 1,000 IUs of vitamin D3 given daily for 12 weeks. The 2,000 IU group was referred to as the high-dose group, while the 1,000 IU was referred to as the low-dose group. The inflammatory biomarkers analyzed included HS, CRP, TNF-alpha, and nuclear factor kappa B. Additionally, IBD QOL scores were also analyzed. The results for high-sensitivity CRP showed a decrease of 23% in the high dose and 6% increase in the low-dose group. However, the p-value was 0.149, showing that these results were not statistically significant. For the TNF alpha, the high dose group had a decrease of 7%, while the low dose group had an increase of 16%, with a p-value of 0.005, indicating that this is statistically significant. Nuclear factor kappa B activity increased in both groups. However, the high dose group had an average increase of 8%, while the low dose group increased by 50%. And finally, the IBD QOL scores for the high dose group increased by 20% and 7% in the low dose group, with a p-value of less than or equal to 0.005, indicating statistical significance. This study shows promising results for doses as low as 2,000 IUs in decreasing systemic inflammation as well as improving disease severity, as was measured using the IBD QOL survey, where we saw scores increase by 8 points in just 12 weeks. Now we'll go over summary and key takeaways. Concerning serum vitamin D status for higher dosages of vitamin D3 given, we saw an average increase in serum 25-hydroxy vitamin D by about 213%. And again, adequate vitamin D status has been associated with improved disease severity and decreased clinical symptoms of IBD. For changes in CRP levels, I've broken down the data into either short or long-term duration. For the studies that lasted between 8 to 12 weeks, CRP levels decreased by an average of 28%, while studies lasting 6 months resulted in average decreases in CRP by 61%. Moving along to tumor necrosis factor alpha, data shows that 2,000 IUs daily for a total of 12 weeks resulted in average decreases of 7%, while the same dosage over 6 months decreased the TNF alpha by 60%. Higher dosages of 50,000 to 100,000 IUs had lesser impacts and reduced TNF alpha by about 16%. Changes in interleukin-6 were only measured in one study, which utilized 50,000 IUs weekly for 8 weeks, and this resulted in a 14% decrease in this specific systemic inflammatory biomarker. And wrapping up our last 3 measured outcomes, we have fecal calprotectin, which decreased by about 48% in the study where participants received 2,000 IUs daily for 6 months. Regarding nuclear factor kappa B, we saw average increases in activity by 50% in low dose vitamin D, which is 1,000 IUs for 12 weeks, as compared to 2,000 IUs, which resulted in only an 8% increase. Last of all, concerning diseases such as Crohn's and ulcerative colitis, serum biomarkers of inflammation are only part of the picture. Perceived quality of life is also an important measure, as the inflammation associated with these diseases can lead to the various symptoms that were covered earlier in the presentation, negatively impacting quality of life. For the shorter studies of about 12 weeks, where participants received 2,000 IUs daily, we saw approximately 20% improvement in IBD quality of life scores, while the groups receiving 2,000 IUs for 6 months showed scores improving by about 45%. Some key takeaways. The 7 research studies discussed confirm that vitamin D supplementation has the potential to decrease CRP, TNF alpha, IL-6, fecal calprotectin, and NF-κB. With a reduction of these inflammatory biomarkers, we expect a decrease in chronic inflammation in the hopes of seeing improvements in clinical symptoms and associated complications. Several studies showed increased serum 25-hydroxy vitamin D status, which involves 2 positive outcomes: decreased risk of vitamin D deficiency and improvements in disease severity. Adequate vitamin D status is necessary for maintaining gut homeostasis, including maintenance of tight junctions within the intestinal lining to prevent leaky gut syndrome, as well as ensuring adequate mucus production within the goblet cells of the epithelium, creating that extra protective barrier. Additionally, we saw that vitamin D has the potential to improve quality of life, as we saw with the increased IBD QOL scores. The majority, going on to some study limitations, the majority of the studies discussed had similar limitations, including small sample sizes. Several of the studies also took place over 12 weeks or less, which may not be enough time to see marked improvements in things like clinical symptoms and inflammation. The studies were also all localized, often recruiting from just 1 to maybe 2 or 3 clinics in just one city. And lastly, the researchers in most of the studies mentioned difficulty in controlling for confounding variables like sunlight exposure and foods eaten that contain significant amount of vitamin D. Some suggestions for additional research include conducting studies utilizing a larger study group, maybe recruiting from simultaneous clinics in different cities and even countries to carry out larger studies simultaneously. Utilizing longer study lengths, such as 6 months or more, as we saw the most promising results with lower doses of vitamin D given over longer periods of time. Though it is difficult, taking extra measures to control confounding variables as much as possible may result in more reliable data. This would include all participants being given sunblock to use daily, as well as submitting 3-day food journals once every 4 weeks to track consumption of vitamin D containing foods. As is usual with most scientific research, there is always more research needed so that different interventions can be tested under different conditions to confirm their measured effectiveness. And here we have references. We've got 3 pages of these. And lastly, I hope that everyone learned something new that can be used in future practice with patients, and I thank you very much for listening.